Our next presenter is Brad Beer. Brad is known for his expertise in treating running and triathlon-related injuries. A physiotherapist with over 17 years' experience, Brad is an APA-titled Sports and Exercise Physiotherapist, exercise scientist, and head physiotherapist for the Super League Triathlon Series. Brad is the founder of award-winning Pogo Physio here on the Gold Coast. He currently consults with Triathlon Australia's Podium Centre athletes and has previously consulted for Triathlon New Zealand and Athletics Olympics athletes, as well as British Triathlon. He is passionate about outputting helpful content for runners, and in 2018 released a revised edition of his best-selling book, You Can Run Pain-Free, a physio's 5-step guide to enjoying injury-free and faster running. Brad regularly writes for 220 Triathlon magazine and hosts weekly iTunes top-ranking The Physical Performance Show podcast. By way of sporting background, Brad spent 12 years competing as a junior elite triathlete before returning to triathlon competition to collect a silver medal at the 2012 World Triathlon Championships in the 30 to 34 year age group. Actually, that is actually and in 2013 win the Australian Olympic Distance Triathlon Championships. I'm excited here. Brad has represented Queensland in the Australian Half Marathon Championships in 2016 and continues to enjoy competing in endurance running events. Brad's presentation today is Managing Bone Stress Injuries in Athletes. Please welcome Brad.
Thanks for the introduction, and Ben, thanks for the opening session. And it's great to be in a room full of people again, isn't it? And as a health professional, I don't think there's any more anxiety-provoking task than speaking amongst peers. So thank you for having me, and I must say, as a sports physiotherapist, I have such great admiration for the work that podiatrists do. We have a podiatrist in our local clinic here, Pogo Physio, Dan. I learn from him every week. So multidisciplinary care on injury and rehabilitation is always so powerful. So it's a real pleasure and honour to be here. This is microscopy of an 80-year-old woman that has just died. A bit morbid, I know. And what we can see here are microcracks. You can see those red lines. If you look at the stains on the right there with purple, you can see them. Quite amazing. I think it's a key place to start to recognise that our bones, apart from the fact that this lady had just passed away and that's her 6th rib, our bones are living, breathing tissues. They are not dead and inert. We're going to talk about bone stress injuries today. And I recall at university thinking that bones were just dead levers that just sat there and didn't do much. I went to Griffith University on the Gold Coast, and one of our course lecturers was Belinda Beck, who's widely known for her work on exercise and bone throughout the world. And so she really turned our class on early to the fact that bone is living, breathing tissue. And that's what we're discussing today. My background already been covered. These are my girls, and then we just had a little newborn as well, little Abby. She is nearly 1 in a few weeks. Aetiology of bone stress injuries. The causation is in the name, right? Bone stress. The bone stress injury manifests when the bone gets stressed. And the bone gets stressed, it's threshold driven by a combination of the number of loading cycles, the magnitude of loading cycles, and the speed at which those loads are applied. In theory, all bone stress injuries are due to workload error. As Ben said, these things can be quite grey when you then look at actually putting them through scientific rigour. But as clinicians, we'd all recognise that typically when an athlete, a person, an individual presents with a bone stress injury, they've done something in the lead up to their presentation. And up to 20% of all presentations, as we probably know as clinicians in the field, are bone stress injuries, or bone stress injury related, I should say. This is a great image from Rich Willie, Brent Edwards, and Stuart Wharton's paper. That is a PCQT image, which is, I think there's only one or two in Australia. I know there's one at Monash University, Melbourne, but you can see here what happens when the rate of bone microtrauma or damage surpasses repair mechanisms. The bone, this is the cortex of the tibia, starts to accrue some porosity, or as you know, some holes in it, if you like. And this is obviously the weak spot. This runner then continues to load that, push through pain and symptoms, and then obviously they progress on the continuum of bone stress injury. It's worth pointing out the timelines for bone remodeling, and that is that it takes about 4 weeks for the osteoclast to get in there and repair remove the damaged bone at a cellular level. But replacing the bone, the cortical bone, that just takes 3 months, and then fully mineralising that bone takes a year. So it's incredible that at any given point we've got 1 million micro cracks in our skeleton, and they're all at varying stages of that timeline. Yet somehow, most of the time, our body manages to get it right. Quite impressive, isn't it? Here's just another fluoroscopy microscope image looking at the remodeling cell coming down the Herbergian canal here, getting that micro crack and doing its thing. And clinically, this is a good point, and this is something that that Stuart Wharton in Indiana University taught me, and that is that clinically, if someone presents in the room with a sore bone or a suspected bone stress injury, typically there may be error a month prior, because it takes a month or 4 weeks for the porosity to actually occur in the bone. Key clinical point. This is a laminate that I have in the consulting room for when bone stress injuries walk through the door. This is a Kiwi triathlete, Hayden Wild, and I give this to patients because I think half of our job as clinicians is honestly education. 30% is probably reassurance, and 20% is the other stuff. And I want to help the athlete, the stakeholders in their care, understand early that when we're dealing with a bone stress injury, we're not just dealing with their workload. There's a whole lot of other factors at play. And I ran into a local foot and ankle surgeon who had literally, I put an image here, just put a percutaneous screw through a young triathlete who wasn't managed well with a navicular bone stress injury. And I said to the gentleman at Coles after hours, I'm doing a talk on Friday on bone stress injuries. He said, just tell them to eat more calories. So, we've got to think beyond biomechanics, we've got to think beyond just their training workload. We need to start thinking about these other factors. So, broadly speaking, they can be divided into the load that's applied to the skeleton, fairly intuitive, and the ability of the skeleton to resist that load, the cumulative progression of the micro damage. Remember that every run, every impact activity that we ever do, there is a micro trauma occurring. That's not a bad thing, that's a good thing. That's how we keep our skeletons refreshed over our lifespan. Load applied to bones, we need to think about the training patterns, obviously the workload, the biomechanics, the muscle factors, footwear, running, surface interaction, quite a big topic there. We won't get too bogged down just yet anyway. And then on the other side, this is an area that I've become hugely passionate around through necessity. I've incurred 6 or 7 femoral shaft bone stress injuries with my recreational running in about the last 10 years. And I've discovered at 36 that my bone density was not what I thought. I popped myself in the DEXA and I was quite disappointed to get my outcome. But I've worked for the last 6 years to improve my bone density, so that's something I like to share with patients. But over here I've circled the 2 big areas that we mustn't forget as clinicians in the field, and that is energy availability and our bone health. Most of us will be familiar with the continuum. This is a handout I give in the clinic as well. I'm happy to share these resources if anyone thinks they'd be of use as well, and send PDFs, etc. I normally draw a happy face over here. When the bone breakdown's been met with adequate repair, the bone's happy, it's not sore, but it becomes accelerated if that workload exceeds the bone's tolerance, and then on it goes to the pathology continuum through to 4A, 4B stress fractures. And this is also a laminate I have in the room with photocopies that I give to patients just to help them understand the gradation that we often typically get reported on MRIs or MRs. The Fredrickson scale, I'm sure everyone's familiar with that, or this I should say. All right, we're on to some, hopefully, clinical things that I've been learning, I continue to learn, and I hope there are some use today. The subjective exam, we all know, is powerful, right? If we have ears to hear, our patients, our clients, runners, athletes, they will tell us what is going on. It is so important. So having the time to listen, look them in the eye, hear their story, is so crucial. And the things that we're going to listen for with potential bone stress injuries are here. Localised bone pain aggravated by loading fails to warm up. If we go back a sec, the innervation patterns of bone is fascinating. The density of sensory nerve endings in bone is biased towards the periosteum. So that wet handkerchief that wraps around the cortex of the bone, think of the tibia or long bone, it's got a density of 100 relative sensory units. I put this around the wrong way, so I do apologise. That's meant to be cortical bone and bone marrow. The cortical bone has a relative density of 1/5 that of the periosteum, then it goes down to 0.1 in the bone medulla inside the bone cavity. Which is why if you have an early onset of a bone stress injury, people often can still single leg hop if we're objectively assessing them, but they struggle to say it's just here, it's this vague feeling of stiffness. In the 6 or 7 I've had in my femoral shafts, they've always started as a feeling of stiffness. And I sort of say you can smell them almost. And the athlete normally knows deep in their heart that something's not right, but runners in particular are great salespeople. They will sell themselves on the idea that they're fine to keep going. So if you start to hear someone, a runner walk through the door and say, hey, look, I'm not sure if I need to be here, let your antenna prick up and think bone first with runners in particular. Also listen out for, and I put this as important to ask questions. I don't know, I didn't phrase that, important questions to ask, but that was probably after hours. Consider what sport they're doing. So if they're a running-based athlete, we've got to be thinking bone, if it's in a region where we normally get bone stress injuries. We need to ask about their prior history. We all know the best predictor of the next injury is their prior history, unfortunately. Training errors, obviously we want to go through and look at that, and it's kind of easy these days to get a quantification of that. We know it's not all about training minutes, it's also the intensity. But, I like to, you're on Strava, you're on Garmin Connect, what do you use? Pull it out, let's have a quick look and take note of that in the initial appointment if you've got time, we'll come back to it. The stage of the athlete's season is really important. So we know that for the running-based athlete, the cross-country, teenagers, recreational runners, elite runners, their likelihood of, or their development of a bone stress injury, I should say, tends to happen as the season goes on. Whereas the field-based sports, the team sports, they tend to get them in the pre-season. Typically because they've been offloaded and they start back and they're doing a lot of high magnitude, fast running with the team. We must think about, is there any signs of relative energy deficiency? And we'll touch on that as we go on, but the risks, if there are, for bone stress go through the roof. Which is why the orthopaedic surgeon says it's just about more calories. Objectively, remember most of the heavy lifting hopefully has been done in the subjective history. We've taken a really good listen to what the patient, the athlete is telling us. And objectively, these are the things that we can do. Obviously, we can palpate. That's great for superficial areas. The end test, the navicular, fibula. If we come to deep injuries, sacrum to a degree, and then it's not so effective, right? So palpation, obviously the metatarsals and some of the tarsal bones can easily be palpated as well. Imaging, I'm sure most of us know MR is the gold standard. However, when it comes to cortical fractures, CT is far superior. Bone loading tests, honestly, these can be hit and miss. That's my clinical opinion. Single leg hopping, you can have an athlete with a bone injury on that continuum, grade 1, grade 2, grade 3, grade 4A, and they can still typically and often hop. Sometimes they can't. I've had grade 3 femoral shaft bone stress injuries, and I remember one time barely being able to walk, but the other time's been able to hop on it. So we can't be so dogmatic with our bone loading tests to say, well, you can do that, therefore you don't have a bone stress injury. It doesn't get us normally on the right path. Fulcrum test for the femoral shaft, honestly that's hit and miss. It's there. Hyperextension for the pars interarticularis in the back, and calcaneal squeeze test. You don't get to do that very often. In 16, 17 years of clinical practice, I think I've seen 3 or 4 in the room. I don't know what everyone else's experiences with calcaneal bone stress injuries. They don't tend to present that often. Don't miss the high-risk sites for obvious reasons, watershed areas, prone to non-union, prone to delayed union, and all the cascades. And I suspect if we've been in clinical practice for long enough, we've all made errors at some point in our career with missing high-risk fractures, and it can really be disastrous for the patient. So please, let us always think bone, and if it's in a region like these, anterior tibial cortex, femoral neck, get it ruled in or get it ruled out really early in the process. And the big mistake I tend to see with these high-risk areas clinically is people they immobilise things, but they don't completely deload things, so strictly non-weight bearing. Or they try, but they don't do it properly because someone hasn't explained the dire consequences if they don't get off that bone. Obviously femoral neck, if it's on the tension side, up here, that's normally a surgical job. If it's compressive side, that can be conservatively managed, 9 or 12 weeks depending, or 8 weeks on crutches. It's a long road. Base of the second met, this is a young track and field athlete. She's got some signs in the shaft there as well, but don't miss the base of the second met. I'm sure you guys are probably far more versed in 5th met stuff than me, but don't miss the 5th met, and don't miss getting them off their feet. This was a good paper that showed that there was 72% successful union with 5th met injuries, bone injuries, when they were fully non-weight bearing and immobilised. And if you compare the difference, 12 weeks of conservative return to sport with surgery took 12 weeks when indicated, versus when they were conservatively managed still weight bearing, it took 24 weeks. Navicular, oh geez, who's had some doozies with the navicular? The navicular is something not to be played around with. These are real patients of mine in this calendar year. Up the top here, sorry, I've got always my head to half the room at any given point. I probably should stand in the middle and try and be like a clown looking left and right. This is a 19-year-old junior elite triathlete who developed the cardinal mid-foot dorsum of the foot, navicular regional pain. I didn't see her at the start. It was managed by a sports doctor who picked it up, but then had her walking around in the boot for 8 weeks before she came out of the boot, asymptomatic at that point, could get through the day without pain. Started to walk around, within a week or two started to get pain again. So they then went to a CT via the orthopaedic surgeon, and this was her decent crack through her navicular. This is her just this week with a percutaneous screw through it. And that young athlete has been dealing with this for, it's been about 7 months now. And if she hadn't got on crutches, educated, diagnosed straight away, she would have probably been fine without surgery. So don't miss those. This is a bit of literature with navicular bone stress injuries showing that 47% of patients that were treated with weight bearing had a successful outcome at nearly 6 months compared to 96% that had only 6 weeks on crutches and a boot. And they got back to sport at about 3.5 months. So there's a huge difference. And the mental toll, when you see this particularly with young athletes, because navicular bone stress tends to be sprinting athletes and often younger, it's huge on them. Treatment of bone stress injuries. This
work is from, in my opinion, some of the leaders in the bone space, Rich Wheely, Brett Edwards, Stuart Warden's paper that they published in Clinical Commentary, looking at low-risk bone stress injuries, so not the high-risk bone stress injuries. This is their six-step framework, if you like, for the low-risk injuries. So we're talking your tibias, metatarsal shafts, fibulas, femoral shafts, etc. Step one, pretty obvious, get the pain under control. Pain's such an inhibitor of muscle function, we can't build strength while they're still sore. Be careful with anti-inflammatories. Obviously, most of us will be aware that can have a negative effect on the bone healing. Consider healing supplements. Low intensity pulse ultrasound. Not a huge, I don't think there's a lot there for it. I popped it up there just to be thorough, and they listed it in the paper, but anti-resorptive meds, there's literature that supports their use for the speeding up of frank fractures in elderly people with wrist fractures, but there's no evidence to support that it can accelerate a bone stress injury healing process. However, you'll often see it used more at the pointy end. I know one of the Olympic marathoners for Australia last year who was on a dose of Fortea or teriparatide to try and accelerate his femoral shaft bone stress injury, pulling out all stops. You must keep these athletes with bone stress injuries cardiovascularly fit. This young guy, that was his Navicnia on the prior page, triathlete. Cross-training, obviously you just have to be circumspect with, if they're a swimmer and they've got a triathlete and they've got a navicular bone stress injury, you might not have them pushing off the wall. Think about those things. Don't forget to find some way to include intensity while they're maintaining cardiovascular fitness. Think creatively and get it in there, whether it's a hand cycle or pick your battles, but find a way to give them some dopamine. Most of the athletes will need it. Muscle function. Bones love muscle, and muscles need bones. So it's an intimate relationship. This is a young guy on the bike there who had the navicular bone stress injury. This is his calf about 4 months after he came out of his boot, and he's still pedaled to the floor trying to get that calf muscle mass back and the plantar flexor capacity back. And this is something that I've really appreciated over the last probably 5 years, is that when we talk about muscle strength, we're not just talking about how many reps they can do or what weight they can shift. We've got to think about it as an integrated, like triangle. We need to think about the ability to generate peak force, because the peak forces we encounter with running sports are huge, like the Soleus up to 8 times body weight. We need to be able to have great endurance, and we need to have great plyometric properties. There's literature to show that smaller muscles are associated with things like metatarsal bone stress injuries, also the medial stabilizers associated with MTSS. So get people moving with strength and conditioning as soon as possible. And a good clinical tip, if this is, say, the athlete's right leg which was injured, which it was, he was doing calf raises almost from day one, even when he was non-weight bearing in a boot. Remember, his foot's not touching on the other leg. Because the literature that's published shows that when people get recurrences, they tend to get it on the leg, the opposite leg when they come back. So don't forget to work the contralateral side. This was Emily Matchelievic's paper along with her colleagues that, I don't know about you guys, but that rattled me when we realised it was published that, it's not just the ground reaction forces that loads bone, it's actually more the muscle contraction on the bone. In the tibia, 6 to 14 times our body weight. That's huge. In the femur, about 4 times here, up to 11 times distally. So muscles load bone. We need to have strong muscles, and we need to have muscles with good endurance to attenuate the loads. And it's a bit of a debate. Do strong muscles contribute to bone stress injury, or are they protective? I think it's a bit of both, but time will tell. Intuitively, it makes sense that people have to be strong. Step 5 on these low-risk injuries for the treatment of them, get people back to sport, obviously, whatever their sport may be. I don't normally get them to write this down, the athlete. It's tissue conditioning on the return, it's not fitness training. So when we get them to start jogging is just that, 50% of their steady pace, and they're normally not happy with it, but it's really important that they don't go too fast too soon. Now, this is a huge important point. Only at intensity once their minutes are restored. So the bone can tolerate the loading cycle increase at a ratio of about 1 to 1. So if someone goes from an hour of running a week cumulatively to 2 hours, they've doubled their relative risk of a bone stress injury. But what the bone has trouble dealing with, at an exponent of 9 times, is the magnitude of load. So if people start running faster with intensity, they need to technically reduce the number of loading cycles in that training week in order to nullify the accumulation of, exceed the potential threshold of the bone. So in simple terms, build volume and only then add intensity. I tell the runner early in the piece, or running athlete, we're not adding any intensity until you're back to 80% of your normal desirable minutes. It's all steady stuff until then. Those that have access might use something like an Alter G or some bodyweight supported stuff. The leather system is quite nice coming out of the US. Treadmills, there's biomechanical differences. We mostly recognise that, but there has been literature to show it reduces typical bone stress load. So, but further up the chain, not so much. So do think about where they're running. MTSS, don't get them running on grass with their return to sport. You might consider some gait retraining and having a look at how they're moving once they're back running. Heiderscheit looked at typical bone stress injuries and showed that the circa 5-10% increase in cadence was a 7% less load on the bone. So that can be a quick win for athletes. Preventing recurrence, consider their workloads, educate the patient. Periodising the year, this is huge. Most runners, talking runners, they just want to run all year, right? But what tissues can tolerate 365 days of loading? I mean, if we think about it commonsensically, it's tough. At some point, those 1 million micro cracks that we've got in our skeleton, something's probably going to not be right. So, Warden, Willie, and Edwards proposed a skeletal reset week. Has anyone heard that term before, that idea of a skeletal reset week? They proposed every 12th week a runner, recreational, competitive, elite, would do well to have a week off. Not training, they can still cross-train, but not loading their skeleton. Just to allow that remodeling process to hopefully not progress to accruing pathological micro damage. It's a hard concept to sell athletes, but it's a very easy one to sell them when they've had a bone stress injury, even easy to sell them when they've had 2, even easy to sell them when they've had multiples. Why 12 weeks? Well, it sort of makes sense, but it could be every 6 weeks. It could be a 50% reduction in workload every 6 weeks. But we need to find some way of periodising it. There's science to show that when rats did this, they went from 4 weeks off to back for 4 weeks and off. They had better increase in bone parameters such as density than when they just continually are exposed. Address bone health as a way of preventing recurrence, obviously. And this has to be done the right way. We have to respect the biology of the bone. So things like, this here, if you're writing notes, you probably already crossed this, but if not, remember that bone cells go deaf after 40 to 90 loading cycles. So they're not responding anymore. The osteocytes they're shut off. So if a runner runs out the door and runs for a minute, at the end of that minute, their bone cells are no longer responding to the stimulus of running. Yet how many people will think that the whole run they're building bone? It's a good thing. They're not. 4 to 6 hours later, the cells are sensitive again, so we can load them again. So if we're trying to clinically work on the bone parameters of an athlete with known bone issues, low density, recurring bone stress injuries, I will say to them, let's do some plyometric single leg jumps or double leg jumps up to 20 or 40 in the morning before you run, because you wouldn't want to do it after it because you're going to get nothing out of it. And then middle of the day, maybe when they get home and maybe just before they go to bed. I've been doing that for about 6 years, and it's one of the things that I think has been helping my bone density. And this is a key point, 10% gain in bone mass can confer a 100-fold increase in ability of the bone to tolerate the working load. So let's get our athletes' skeletons better. This top chart here, this is a guy I've been sitting in the clinic. He's the Australian Ironman triathlon champion for the 40 to 44 age group. And he went overseas here, didn't have his bike. He's training for the Hawaii Ironman champs in like 5 weeks, the world champs. And he did a lot more running than usual.
and then he pulled up with a tibial bone stress injury grade 1, so he's sneaking his way back now, but he's working diligently to try and improve things with 4 weeks to go. High risk bone stress injuries, this is not